Speaker. The opposition position on this bill was provided in the House on Tuesday, the 8th of October 2024. I would like to respond to the bill as Shadow Assistant Minister for Regional Health on the regional perspective through the prism of the Regional Aged Care Summit that I convened in July 2023. Before I do so, I want to commend the Shadow Minister for Health, Senator Anne Ruston, for her efforts negotiating with the government on this bill. She secured many significant changes from the government, one of which was negotiating what was going to be a 17.5% inclusion of assets for contribution toward care costs, which is down to 7.8% now. For older Australians who have paid their taxes, who have not had the benefit of superannuation, who have worked hard to ensure that they would not be a burden on society in their retirement, who made significant sacrifices and volunteering contributions to their country, it sticks in their craw that an arbitrary and immediate date threshold will now see some of them contributing so much of their assets to the cost of their care in later years, when in the home or a room beside other people who made far less effort for their country, who contribute nothing and get the same care for free. Given the chronic obstacles aged care providers tell me about in delivering quality and equitable care in regional areas, I hosted the National Regional Aged Care Summit in Mildura in 2023, bringing together frontline workers, providers and peak bodies from across Australia to consider policy solutions to the many problems that they face. Government ministers were invited but did not attend, nor did departmental or aged care quality and commission representatives, but they undertook to receive and respond to a copy of the summit communique. It took some time to get a response, and to say it was underwhelming is being kind. So, to do justice to the 100+ attendees at the summit, I will review this bill by stepping through that summit communique. Regional aged care services face similar difficulties to the broader healthcare system in rural and regional Australia. There is a significant shortfall in workforce, leading to understaffed and under-resourced services, which ultimately means older people in regional areas receive a lower standard of care than their metropolitan counterparts. And I will come back to workforce issues a little later. The first topic that we surmised on that day was regional residential aged care viability. There is a cost premium for delivery of regional, rural and remote aged care that needs to be recognised and addressed by government under the equity principle. This is reflected in travel costs for clinical staff and providers to deliver services to rural patients, capital and maintenance costs for regional aged care facilities, and increased expense of service delivery compared to urban areas. Solutions to this cost premium must be adopted to ensure viability of the sector in regional Australia. The summit proposed that funding must increase to recognise regional cost pressures. I'm pleased to say that Senator Ruston managed to negotiate a $300 million fund for regional service providers. Funding grants should be made available to assist providers to manage the disparity in economies of scale compared to urban counterparts, including affiliating with other providers and cooperative partnerships in local care economy that extends beyond aged care to other healthcare services. Government and providers should explore innovation, including technological solutions to improve efficiency and reduce costs, telehealth consults, AI support and digital health and medical records for residents to better manage healthcare delivery. Communities should work together to make aged care a community-level activity and, more broadly, conceptualise aged care not as an independent sector but rather part of the local care economy. This would overcome fragmentation of service delivery and poor economies of scale. Innovation should include co-location of health, aged care and childcare facilities and provide pathways to achieve economies of scale and staff retention. The Regional Aged Care Summit, held in Mildura in 2023, looked at the modified Monash model and considered it ineffective and not fit for purpose, with geographical, social and economic framing, resulting in clear disadvantages for regional Australians, particularly those living in modified Monash model Category 3 and 4, such as Mildura, my own hometown, and fails to acknowledge the cost of workforce attraction in those regions. Aged care facilities are paying 3 times the average nurse wage for agency nurses and, of course, for FIFO locums who come in and out. This creates an intolerable burden on their budget. Yesterday, there was a release of the Medicare reviews, including workforce, the modified Monash model, distribution priority areas and the distribution workforce shortage mechanisms. The government released the Working Better for Medicare review report and the review of general practice incentives expert advisory panel report with Minister Butler acknowledging to the Royal Australian College of General Practitioners that morning that he is constantly lobbied on the distribution priority areas and modified Monash model. From the moment Labor changed the DPA, I've been calling out the negative impacts it has been having on regional Australians. The Working Better for Medicare review found that the current method of determining DPA status via automatic application of modified Monash Model 2 to 7 blankets means that of the 827 GP catchments across Australia, 85% now have DPA status. The almost universal view of submissions and consultations suggests DPA in its current form is no longer an effective distribution lever. It is proposed that the MMM should no longer be used to establish blanket rule exemptions and determine that each GP catchment would individually be accorded DPA or non-DPA status. And thirdly, it held that a similar mechanism, the distribution of workforce shortage, was no longer fit for purpose, saying there are too many areas within cities and heavily populated centres outside those cities that are classified as DWS. In short, the review says what I've been saying for years and what the Regional Aged Care Summit said and communicated to the government a year ago, that the modified Monash model is no longer fit for purpose and Labor have wrecked the DPA workforce lever to shunt far too many international medical graduates into suburban areas of capital cities. Poor primary and preventative care services through a lack of doctors results in people developing poorer health and entering acute care services, which are far more expensive and including residential aged care sooner. The Regional Aged Care Summit communique stated that regional aged care is a poor cousin to the urban care economy and a victim of sectoral competition, not just with acute care but now with the National Disability Insurance Scheme. Governments must, to the greatest extent possible, remove perverse incentives which prioritise motivation to practice in other areas of the care economy in preference to aged care. For example, wage differentiation between the public health system, hospital system, versus the private or public aged care system. Regional private and not-for-profit providers suffer, in particular, from an administrative burden of regulation, one could almost say over-regulation, that should be addressed by government and the regulator. A government subsidy system must be established to support not-for-profit aged care providers in a way which balances the advantage state-funded public aged care facilities have in top-up funding per bed per day and a backing for running at a loss, which 70% of not-for-profit facilities currently experience. That is extraordinary. Community-led home care services represent a strong model for regional Australia, providing local residents with a sense of community, purpose and assistance from people who know the community. While there has been a slight improvement, the silent waiting lists for elderly regional Australians, namely access to ACAT, aged care assessment teams, and the time lag between home care package approval and implementation remains unfairly delayed in regional Australia. This brings me to the question of grandfathering arrangements proposed under this bill. The government has signalled that those in the system at the time of the government's announcement of this bill will benefit from existing arrangements and will not have to pay more for their care. Firstly, that is effectively legislation by press release, and that is problematic. Secondly, what if someone applies for an aged care place before 1 July 2025, or whatever the start date is settled at through this legislative process, and has or has not received a place? Are they both grandfathered? What if someone applies on the 30th of June 2025? 2022 data showed that more than 50,000 older Australians died while waiting for approved home care since July 2017. Access to home care packages for older Indigenous Australians is a particular issue, and face-to-face information regarding ACAT assessment provided by Indigenous health services and workers is a preferred model to the current information on the My Aged Care website and reading materials. The cost premium for regional services means that home care packages are not fully being met and not fully meeting the needs of recipients. As one constituent, Rose, pointed out to me in the last couple of weeks, she has an $80,000 package in her home care funding. But what she really needs is cataracts. As she points out, there is little point installing home help if she cannot see, because she will not be able to live at home. The wait times in Victoria's public health system are so bad there could be permanent damage to Rose's eyes by the time she receives cataract replacements. But her package money could be used, and she could save her eyesight and continue to live at home. The situation highlights the broader problems in the care funding arrangements, the legacy arrangements of different silos of Medicare, aged care, NDIS and other funding streams, and whether we need to be looking holistically at federal health funding to focus on outcomes, not process. I even had one constituent in his early 60s asking if he could access his superannuation to address his need for cataracts, as he was getting little help from his fund. These are the lengths older Australians are trying to go to ensure quality of life in their latter decades or years in the absence of appropriate regional health care. In my view, this is an absolute priority. We know that preventative primary care saves a lot of money for the federal government by keeping people out of tertiary care. This is the same in aged care, and the government needs to focus on how to assist older Australians to stay at home. The Regional Aged Care Summit recommended a growth funding round for CHSP, or the Commonwealth Home Support Program, is required to enable more providers to enter the market in regional areas. Capital funding should be targeted at a needs-based approach, and government must acknowledge that smaller providers may not be able to invest the same time and funds in grant applications as larger providers, and take this into account when awarding grants. The market cannot always be relied on to provide aged care services in remote parts of Australia. Deputy Speaker, I don't have time to go through the rest of the Regional Aged Care Summit communique, but I just want to say that regional Australia needs to have a priority place in whatever funding and proposals and mechanisms are put in place by this government, and I urge the government to look at this more seriously.